Hey everyone, and welcome! We're about to jump into a super high-yield masterclass that's all about building your confidence to totally crush one of the biggest topics on the NCLEX, fluids and electrolytes. So let's get right into it and make sure you're ready for any question they throw at you. So here's our game plan. We've set this up to work just like your brain needs to work on the exam and on the floor. We'll kick things off with fluid balance, then we'll hit the big electrolytes one by one, focusing on what they do to the body. And we'll wrap it all up with a classic who do you see first question. All right, first up, fluid volume balance. We're going to really zero in on fluid overload here. Trust me, this is a core concept you'll see over and over again. Okay, so what is fluid volume excess? At its heart, it's pretty simple. There's just too much fluid in the tank. But our job as nurses goes deeper. It's not just about getting the fluid out. It's about figuring out why it's there in the first place so we can get things back to normal. Now, here's where it gets interesting. Not all fluid overload is created equal. With isotonic, you've just got too much fluid in the bloodstream, which can overwhelm the circulatory system. But with hypertonic, all that extra sodium is literally pulling water out of your patient's cells. And then there's hypotonic, we call this water intoxication, where fluid rushes into the cells, making them swell up and watering down all those electrolytes. So what are we going to do about it? Well, your number one job always is to assess. You're listening to the lungs for crackles, checking for edema, then you act. We give diuretics to help the kidneys get rid of that extra fluid, we restrict fluids and sodium, and we track daily weights. Pro tip, daily weight is the single best way to track fluid status. And all the while, you're watching those labs like a hawk. Okay, everybody listen up. This is a huge NCLEX alert. If a patient's kidneys aren't working right, they can't pee out the fluid. It's that simple. The main exit is blocked, so everything backs up. That's why your patients with kidney disease are at the absolute highest risk. You have to be watching them so carefully. All right, moving on. Section 2 is all about potassium. From now on, whenever you hear potassium or see K+ on a test, I want your brain to immediately go to one place, the heart. It is absolutely the most critical electrolyte for cardiac function, period. This number right here, you have to know it. Burn it into your brain. Normal potassium is 3.5 to 5.0. No ifs, ands, or buts. It's just that important. And this slide shows you exactly why that range is so tight. Just look at the heart. Whether potassium is too low or too high, what happens? A weak, irregular pulse. It's because potassium messes with muscle contraction. So how do you tell them apart? The ECG is your key. Low potassium gives you that ST depression and a prominent U wave. High potassium, that's when you see those scary, tall, peaked T waves, unmistakable. So your patient's potassium is low. What's the very first thing you do? Before you even think about giving potassium, you get them on a cardiac monitor. You have to see what the heart is doing. Then we can start to replace it safely, either with pills or a super careful IV, while also making sure they don't fall because of that muscle weakness. And for high potassium, same first step, get them on the monitor. Then stop any and all potassium going into their body. If their kidneys work, diuretics can help flush it out. If not, we use meds like K-oxalate to pull it out through the gut. And in a real emergency, we might give IV calcium. Now listen, this is key. The calcium doesn't lower the potassium level. It acts like a shield to protect the heart muscle from potassium's dangerous effects. Okay, I need everyone to hear this loud and clear. This is one of the biggest, most important safety rules in nursing. You never, ever, ever give potassium as an IV push. It will stop the heart. Instantly. This isn't just a test question, this is a life-saving rule. So after that giant warning, let's talk about how to do it the right way. These are the golden rules for IV potassium. It always has to be diluted in a big bag of fluid. It has to be infused slowly, usually no more than 10 per hour. You've got to watch that IV site constantly because potassium is super irritating to the veins. And you absolutely must make sure the patient is peeing before you start that drip. All right, let's switch gears. We're moving from the heart up to the head. Section 3 is all about sodium. And when you see sodium, or Na+, I want you to think brain. Just like potassium, this is another one of those lab values that's completely non-negotiable. You have to memorize it. Normal sodium is 135 to 145. So what's the big deal with sodium? Look right at the top line for both columns, central nervous system. Whether sodium is too high or too low, the brain feels it first. We're talking confusion, seizures, even coma. So if your patient suddenly has a change in their mental status, your first thought should be, I need to check their sodium. Your priority assessment is always neuro. And here is a classic NCLEX trap you need to know about. The kidneys sometimes have a hard time telling the difference between sodium and lithium. So if a patient's sodium level is low, their kidneys will try to hold on to sodium, but they accidentally hold on to lithium too, and that can lead to lithium toxicity, which is really dangerous. Okay, on to our next electrolyte team. We're going to talk about calcium, magnesium, and phosphorus all together. Because you know what? They're like best friends who have these really important interconnected relationships. Let's do a quick hitter review right here. For low calcium, the classic signs are Trousseau's and Chov-Steck's. This is basically neuromuscular excitability, or tetany. For low magnesium, think hyperreflexia and seizures. See a pattern? The central nervous system is just way too fired up. And here's that relationship I was talking about. It's super important. I want you to picture a seesaw. Calcium is on one end, and phosphorus is on the other. If phosphorus goes down, what happens? Calcium has to go up. And if calcium goes down, phosphorus goes up. They have this inverse or reciprocal relationship. It's a great trick for the test. What's calcium's main job in the body? Building strong bones, right? So it makes perfect sense that anytime calcium levels are off, doesn't matter if it's high or low, the bones are at risk. This means your patient could get a fracture from something as simple as turning over in bed. So your number one nursing intervention is safety. Move them gently, move them carefully. Here's another one of those must-know life-saving facts for your exam. If a patient gets too much magnesium, it causes severe muscle weakness and can stop their breathing. What's the antidote? It's calcium. Specifically, we give calcium gluconate. It works immediately to reverse the effects of that magnesium overdose. All right, we've gone through all the major players. For our last section, let's bring it all home and review the most important ECG changes that you absolutely have to be able to spot. You guys, this table is pure gold for the NCLEX. It shows you exactly how these electrolytes mess with the heart's electrical wiring. Now, if you can only memorize two of these, please make it the potassiums. Low potassium, look for that prominent U wave. High potassium, those deadly, tall, peaked T waves and a widening QRS are basically screaming at you that your patient is about to have a cardiac arrest. And so we're going to end with this. A perfect, classic NCLEX prioritization question. You've got 4 patients. They all have something wrong with them. Who are you running to first? Who's the sickest? Always go back to your basics. Airway, breathing, circulation. Which of these is the biggest, most immediate threat to your patient's life? I'll let you think on that one. If you apply everything we just talked about, you will know exactly what to do.